The next presenter is Ms. Anna Tallmadge from Clinical Health Access Initiatives, CHI, in Malawi. She's going to present the abstract number 9, Right Under Our Nose, a simple screening tool to identify HIV-positive children outside the PMTCT program at Outpatient Department in Malawi. Ms. Tallmadge, please.
Hi, everyone. My name is Anna. I'm a program manager at the Clinton Health Access Initiative in Malawi. And over the last 2 years, my team has been supporting the Malawi Department of HIV and AIDS to develop a simple screening tool to identify HIV-positive children between the ages of 2 and 12 years old who are not currently being caught by the PMTCT program. So currently in Malawi, about 1 in 3 HIV-positive children has not been linked to treatment. And we see that pediatric treatment coverage has continued to lag behind adult treatment coverage. So together with our ministry colleagues, we started to really reflect on who these missed children are and how we could go about engaging them in care. We know that Malawi already has a very strong PMTCT program and that linkage of known HIV-positive children is high. So we suspected that the majority of these untreated children are actually undiagnosed, either because they had been infected postnatally or because they had defaulted from care. So the nuance there is that we think this is primarily an identification problem rather than a linkage problem. And so if we set up systems to diagnose these remaining children, that would effectively close the pediatric treatment gap. So next, we started to consider where we would go about looking for these undiagnosed children. In Malawi, data suggests that children in this age group do have frequent contact with the health system. So that means they are present in health facilities and available for testing. We just had to figure out how to go about testing them. So our first option would be just to test all children at health facilities. But we ruled that out pretty quickly because there are insufficient resources to implement universal testing. And regardless, it would be very inefficient since prevalence in this population is so low. So if we're going to target testing, one option is to test all sick children. However, the sensitivity of this is also low since there are so many factors in general childhood illness. And additionally, by the time a child starts manifesting clinical symptoms of HIV, that's often pretty late into disease progression. And ideally, we'd want to identify these children earlier. So a third option would be to introduce a screening tool. And this certainly seemed more feasible than universal testing. However, we had a negative conception that screening tools are usually pretty difficult to use and fairly time intensive. And additionally, most of the tools we've seen are based on reviewing constitutional symptoms, which is also not a very sensitive indicator for HIV in a setting like this. But as you may have guessed, we did proceed with option number 3. And in doing so, we tried to commit ourselves to creating a screening tool that was not only effective, but also fairly simple, easy to use, and quick to administer. So as we started to develop this tool, we realized there was an opportunity to approach screening in this age group in a very different way. Because the thing is, the primary risk we have to assess in this age group is maternal exposure. So in our view, once a mother has been confirmed HIV negative at the end of breastfeeding, there's very little HIV risk for the child until such time that they initiate sexual activity, which surveys suggest is around age 13. So for this age group, we hypothesized we could screen children simply by reviewing their mother's testing history. So the screening tool we ended up developing is formatted as a simple checklist. Essentially, every time a child between 2 and 12 years old presents to a health facility, the screening personnel completes a new screening slip. So first, you'd start with a review of the mother's testing history, either by looking at her patient card or by taking a verbal report. You'd check off the applicable testing history, and the tool would send you down a series of pathways with customized decision trees. So essentially, the screening tool is seeking to confirm that the mother was HIV negative at the end of the breastfeeding period, thus ensuring that mother-to-child transmission risk is known. If the mother's status had not been confirmed since the end of breastfeeding, she's referred in directly for HIV testing. And if she tests newly positive, her children are also screened in. The tool also has provisions for if the mother is deceased or absent that day or previously known positive. We piloted this tool last year and collected over 8,000 screening slips for review. And this provided some really interesting and detailed findings, which are summarized here. But for the sake of time, I'll point to just two key takeaways. So firstly, we see that about 1 in 4 mothers did not have a confirmed HIV status since the end of breastfeeding. So these mothers were referred for same-day testing, and of those who accepted, 1.9% tested newly positive. Children were referred for testing when they had defaulted from care, or the mother's status could not be determined, or their mothers had tested newly positive or inconclusive that day. So with these criteria, just 8% of total children were referred for testing. And of those who tested, 3.9% were diagnosed newly HIV positive. So we view this as a very compelling result because we were able to target testing in such a way that only the children who could have had maternal exposure are referred for testing. And in doing so, we did effectively identify new diagnoses at a yield rate that far exceeds the national average in this age group. So overall, we found that this tool effectively identified mothers and children who were eligible for HIV testing, and it did so by promoting efficient pediatric testing without posing a strain on resources or healthcare worker time. This style of screening is very intuitive, and we saw that it effectively complemented the strong PMTCT program by putting focus on filling the gaps in our existing interventions. So please feel free to contact me at the email address provided at the bottom of this slide to discuss further. But otherwise, thank you so much for listening.